Here we present a case of a balloon test occlusion on a patient who had a very large skull-based tumor, possible a meningioma that was embedded in the right carotid artery and possible the basilar artery. Prior to surgery, it was important to know if the patient could tolerate a artery occlusion. This is the MRI showing the very large skull-based tumor, and as you can see, the internal carotid artery is within the tumor itself. So in preparation for surgery, it's important to know whether the patient could tolerate a sacrifice that carotid artery. So under conscious sedation, a right femoral artery access was obtained using a 8-frame sheath, so we can accommodate a large balloon guide catheter. This is obviously under conscious sedation, so we want the patient to cooperate. We started with the left internal carotid artery, cervical view, and also intracranial view, and we can see that there is minimal to no flow into the right internal carotid artery distribution. So the left internal carotid artery is not supplying significantly to the other side. We similarly do an angiography of the vertebral artery to see if posterior circulation contributes to anterior circulation through a posterior communicating artery, and as you can see, there is minimal to no flow coming from the posterior circulation into anterior circulation. While we're doing this, we are giving 6,000 units of heparin to the patient because we want to achieve a ACT larger than 300. Selective right external carotid artery demonstrate a significant amount of tumor blush that could also be embolized in preparation for surgery. We also then do a baseline right internal carotid artery injection cranial view to see the entire vasculature of the brain. All this is to have a baseline angiography prior to the balloon test occlusion. Doing an exchange, we bring a balloon guide catheter on the roadmap using an exchange glide wire. As you can see, the balloon catheter has been prepped and is ready to be inflated. We want to accommodate the catheter carefully into the internal carotid artery and establish complete flow arrest and to prevent a false negative result. While injecting contrast, we inflate the balloon, and that would tell us that there is flow arrest with flow stagnation, as you can see here. So now that we have occlusion of the right internal carotid artery, we lift the balloon up there for 10, 15, 20 minutes until the patient tolerates. And we continuously check with an X-ray to make sure that the balloon remains inflated and we actually have flow arrest. At times we do a quick puff to make sure that there is still flow stasis. We repeat this maneuver 2 times, inducing hypotension to have a better reliable balloon test occlusion. And if the patient remains neurologically intact, we could tell that the patient did pass the balloon test occlusion. Thank you.